Hello everyone, Dr. Alex Vasquez here with video number 2 in this series on cardio nutrition. Today I'm going to talk about structural and functional importance of urinary alkalinization against mild metabolic acidosis. Today I'm going to start by reviewing the following articles, 3 of which are new, and the 4th is one that I introduced in cardio nutrition number 1, and I'm going to discuss that in more detail today. First, of course, we want to start by defining what it is we're talking about. And the topic today, as I've already mentioned, is metabolic acidosis. And here I'm going to talk about subtypes per cause and severity. These divisions and categorizations are my own ways of thinking about this situation, but I still think that it's clinically relevant. Even though these terms and nomenclature are not necessarily official, we just look at things here from kind of a common sense perspective. So when we talk about metabolic acidosis, we all, of course, appreciate that in some cases metabolic acidosis can be very severe. The context here is a very complex condition and major deviation from normal physiology, which is always resultant from a serious cause, and that cause itself must be treated directly while other resuscitative interventions are applied. Severe metabolic acidosis is characterized by decreased blood bicarbonate levels with blood acidemia, also reduced carbon dioxide secondary to the compensatory hyperventilation. This is typically divided into increased or normal anion gap acidosis. Typical causes include diabetic ketoacidosis, lactic, alcoholic, and poisoning acidosis, uremia, and renal tubular acidosis. Severe metabolic acidosis needs to be treated in the emergency department and is generally then followed by hospital admission. Category number 2 here is a more moderate level of metabolic acidosis. We see this in patients with renal insufficiency or overt renal failure. Treatment interventions can include administration of alkali, supportive medical care up to dialysis, and functional nutritional interventions to restore renal function. I've discussed that in my books now for about 10 years, and that information is also updated in the most recent version of Inflammation Mastery. Next, let's talk about mild metabolic acidosis. This is typically diet-induced metabolic acidosis and is extremely common, characterized by a urine pH of approximately 6.5, and the treatment here is diet modification and as-needed administration of citrate and bicarbonate. I think that we could also look at a 4th category of metabolic acidosis relative to excretory needs in patients who have been acutely poisoned. This was discussed in a landmark publication by Proudfoot and co-authors published in Journal of Toxicology and Clinical Toxicology in 2004. I'll talk more about that position paper during this presentation, but the clinical context here is acute poisoning, typically in a hospital setting. The specifically recommended treatment for alkalinization in this setting is intravenous sodium bicarbonate. But I'd also like to state here that a reasonable argument can be made that we're all poisoned with various chemicals and pesticides, and that therefore urinary alkalinization probably has therapeutic and preventive medicine benefits for just about the entire population. Also, a 5th category here, we could say relative functional or therapeutic preventive intervention with urinary alkalinization might also be used for the prevention and treatment of addiction, osteoporosis, insulin resistance, renal deterioration, and renal stones, nephrolithiasis, also sarcopenia. I'll talk more about those again during this presentation. And the treatment here would be same as number 3, which is diet modification and the as-needed administration of citrate or bicarbonate to reach a urine pH, let's say, of at least 6.5 and perhaps 7.5 or even higher than that. Again, I'll give you more details as we go through today. So let's talk about why this is important. Let's look at some clinical applications specific to disease treatment and prevention. The take-home message here is that urine alkalinization has many effects by several mechanisms to improve various systems, and together this promotes beneficial clinical outcomes. So let's look at number 1, osteoporosis, and I've given you some footnotes here to kind of help you connect the dots. I'll show you that in just a moment. But osteoporosis has been shown to benefit from urinary alkalinization, as has insulin resistance, hypertension, hypercortisolemia, renal deterioration, and urate and oxalate nephrolithiasis. Urinary alkalinization also lowers serum uric acid, thereby alleviating insulin resistance and hypertension. It also helps to prevent or alleviate sarcopenia due to diminished appetite and also glutamine catabolism. At least one study has shown that urinary alkalinization helps to alleviate the cravings that lead to addiction. Also, urinary alkalinization has been shown in at least one or two clinical studies to alleviate chronic pain. Also helps to alleviate diminished appetite. And some of these particular benefits might be due to low dopamine or catecholamine levels, which are increased following urinary alkalinization. Also, endorphin levels are increased following urinary alkalinization. Urinary alkalinization also helps to prevent and treat magnesium deficiency, and of course that provides us with a myriad of various clinical benefits. Again, I've detailed all of this in my book, Inflammation Mastery, 4th edition. The first section of that book was also published in a separate volume called Textbook of Clinical Nutrition and Functional Medicine, in that case, volume number 1. But again, the take-home message here, if you look at the 12 different items that I've listed here, is that urine alkalinization has many effects by several mechanisms to improve various systems and promote beneficial clinical outcomes. And I'm sure you'll agree that this is relevant to a lot of conditions that we see routinely, if not daily, in clinical practice. So now let's dive into the review of those 4 specific articles that I listed previously. We're going to start right now looking at this article, Luminal Alkalinization Attenuates Proteinuria-Induced Oxidative Damage in Proximal Tubular Cells. You can see this was published in the Journal of the American Society of Nephrology in 2011. This is an in vitro study with proximal tubular cells, and it was followed by a mouse study. Some of the key points of clinical relevance include researchers found that in the setting of proteinuria, and that is protein loss by the kidneys, acidic urine leads to the enhancement of oxygen-free radical production, specifically superoxide free radical, by renal cells, specifically via the following mechanism, and that is proteinuria plus acidic urine leads to phosphorylation of the intracellular pH sensor called PYK2 or PYK2, and this quickly leads to activation of NADPH oxidase, which produces the superoxide free radical. The authors go on to state, sodium bicarbonate feeding selectively alkalized the urine and dramatically attenuated the accumulation of superoxide-induced DNA damage and proximal tubular injury. Overall, these observations suggest that luminal acidity aggravates proteinuria-induced tubular damage, and that modification of this acidic environment may hold potential as a therapeutic target for proteinuric kidney disease. Before moving on to the next article, let's take a look at this article itself and also look at one of the diagrams, which I think really helps to explain what's going on in the kidneys when they're faced with a chronically acidic environment. So as you can see here from the first page of the article, the last line in the abstract states, overall, these observations suggest that luminal acidity aggravates proteinuria-induced tubular damage. So basically what that means is that the acidic environment of the kidney, if the kidney doesn't have enough alkaline reserve, we might say, this leads to accelerated renal degeneration, or we might say rapid biological aging of the kidneys. Also, looking in the first paragraph of this article on the first page, we see that reactive oxygen species are abundantly generated in the proximal tubular cells through the reabsorption of urinary albumin. So again, when protein is excreted from the kidneys, the reabsorption of that protein induces the formation of damaging oxygen-free radicals, specifically superoxide. And the authors provide a bit more detail by stating, subsequently, these receptor albumin complexes activate protein kinase C signaling pathways, which leads to NADPH oxidase-mediated free radical generation. Now let's look at an image from this article, which I think is very clear in its depiction of the pathways involved and also the clinical implications of those pathways. Here, the authors provide more explanation of the intracellular signaling mechanisms involved in this albuminuria-induced superoxide production, again, in renal proximal tubular cells. And look at what they state following. They state, proteinuria associated with physiological lumen acidification cooperatively induces robust PYK2 activation in proximal tubular cells. The activated PYK2 induces extensive ROS accumulation through activation of, ultimately, NADPH oxidase, which produces the superoxide free radical. Now let's move on to the next article. The next article is titled, Bicarbonate Supplementation Slows Progression of Chronic Kidney Disease and improves nutritional status. You can see this was published again in the Journal of the American Society of Nephrology, 2009. This is a randomized clinical trial involving 134 patients with chronic kidney disease with a creatinine clearance of between 15 and 30 milliliters per minute. So this is pretty major kidney disease at this level. This is stage 4 kidney disease. These patients need to be managed by a nephrologist or internal medicine specialist. And in this study, they were treated with sodium bicarbonate for a period of 2 years. Key points of clinical relevance here: the decline in creatinine clearance was slower with bicarbonate supplementation. So again, alkalinization is helping to preserve kidney function. Patients supplemented with bicarbonate were significantly less likely to experience rapid progression to end-stage renal disease. This was 9% in the bicarbonate group versus 45% in the untreated group. Again, here the authors state, similarly, fewer patients supplemented with bicarbonate developed end-stage renal disease, 6.5% versus 33%. Obviously, that's a very huge difference. Nutritional parameters improved significantly. This included improved food intake, better muscle and fat mass, increased arm circumference, increased serum albumin, which may have been due to the improved food intake and also due to reduced catabolism of glutamine for urine alkalinization. Toward the end of the article, the authors conclude the importance of an optimum acid-base status for positive clinical outcomes and survival has been acknowledged by kidney disease outcome quality initiatives and the European Renal Nutrition Consensus that recommends maintaining a serum or plasma bicarbonate level of at least 22 millimoles per liter. Again, before leaving this article, we'll take a look at the first page of it. Bicarbonate supplementation slows progression of chronic kidney disease and improves nutritional status. Again, this was published in a major nephrology journal in 2009. I'll read to you some of my highlights here. Bicarbonate supplementation slows the rate of progression of renal failure to end-stage renal disease and improves nutritional status among patients with chronic kidney disease. Let's look at the first paragraph, which states, metabolic acidosis, generally perceived by clinicians as a low plasma bicarbonate, particularly when the GFR falls below 30 milliliters per minute. This, in turn, may bring about a variety of sequelae, such as stunted growth in children, loss of bone and muscle mass, negative nitrogen balance, and the possible acceleration of the progression of chronic kidney disease. Again, they noticed